All right. Hello, everyone. We'll just give it another minute here as folks are coming into the room. All right. Good afternoon, everyone, and thank you for joining us today. I'm Josh Miller, Project Manager with the Rural Health Redesign Center, helping to oversee the Northern Border Region Technical Assistance Center. And I'm pleased to be joined by my colleague, Tom Harlow, Project Director for the NBR TAC. We're excited to have you all with us as we explore innovative approaches to improving healthcare for rural communities across the Northern Border region. Last year, in September 2023, our center was honored with a one-year supplemental award from the Federal Office of Rural Health Policy in partnership with the Northern Border Regional Commission. This funding supported 7 innovative projects in Maine, New Hampshire, New York, and Vermont, each focused on addressing critical healthcare challenges in rural areas, ranging from opioid and substance use disorders to food insecurity, health equity, leadership development, mobile integrated care, access to primary care, and pediatric oral health. Today's webinar is an opportunity to highlight the incredible work of these projects and share best practices that have emerged. We'll hear directly from each project lead about their strategies and outcomes, giving us valuable insights into how rural healthcare can be transformed through collaboration and innovation. Before we dive into the presentations, just a few quick housekeeping items. We ask that you submit any questions you may have in the designated Q&A section. We'll do our best to answer as many questions as we can during the session, but if we run out of time, rest assured that we will address any outstanding questions when we release the session recording. We appreciate your active participation and understanding. Without further ado, I'll turn it over to Katie for our first presentation.
Thanks, Josh. Hi, everyone. My name is Katie Butler. I am the Director of Research and Innovation for Community Care Partnership of Maine. And I'm going to be speaking today to our ECHO learning community, which was established to address OUD in Maine's rural health centers. Next slide, please. A bit of an introduction and some objectives for our program. We established the ECHO learning community, which we affectionately call Project ECHO, to support providers and care teams, namely in Maine's rural communities, in offering low barrier access to MOUD or medication for opioid use disorder treatment. The primary focus of the work is to improve clinical and operational knowledge of various formulations of MOUD, but particularly extended release buprenorphine, with the ultimate goal of improving access to MOUD treatment across Maine. Next slide, please. Some key components of Project ECHO. A traditional ECHO format has 2 main components, which are didactic presentations and case reviews and discussion. So our program implemented both of those elements, but we also had a resource repository or developed a resource repository inclusive of policy and procedure templates, workflows, an index of validated behavioral health screening tools, conversation guides for providers, and just other things that would support our participants in treating patients with OUD and administering MOUD. For the other 2 primary components of an ECHO model, we met monthly. We gave didactic presentations. Those were presented by subject matter expert faculty, which was sort of a rotating cast of around 8 folks, inclusive of clinical pharmacists, providers with experience in treating addiction and pain, behavioral health providers, medical directors, and a peer recovery coach. We also had a psychiatrist on that faculty. And then case presentations, which were prepared and presented by our provider participants on real patients with OUD, and then a discussion on each case, which was facilitated by a member of our ECHO team to offer sort of a platform for providers to learn from each other and discuss shared experiences in treating OUD. We call it sort of an all teach, all learn approach is the name of the game. Next slide, please. So some program outcomes, I've included the list of topics that we covered with our didactic presentations. There were a few others, but I felt these were the most important to highlight. And then in the figure on the right, you'll see the map of our Project ECHO participants. We were able to reach practices as far northeast as Caribou and as far southwest as Porter, Maine, about 20 miles from the New Hampshire border. So quite the geographic reach across a pretty large state. Some of the presentation topics that I think are important to call out that I think were most consequential or impactful for our participants were the didactic presentation on initiating MOUD in the primary care setting. That's an incredibly difficult task and not one that a typical primary care provider would know how to do or necessarily have the resources to carry out that MOUD initiation. It's incredibly complex care. Patients can go into withdrawal and need comfort care. They also need, just trauma-informed, compassionate care. So being able to speak to that with our participants was really important, really impactful, we believe. Another area that we were really focused on was managing common comorbid psychiatric illnesses with OUD. So where we know that Maine is a state that may not have the best access to behavioral health care, it was great to have behavioral health providers and psychiatrists on our faculty to really speak to some of the nuances of treating patients in that population. Next slide, please. Some key challenges and the strategies that we deployed to address those challenges over this past year or so of operating this program. The first and probably foremost was difficulty in capturing provider time. Particularly in rural health centers, it's difficult to get providers on a call without disrupting clinical schedules. So we had to be creative in the ways that we address this. So the first was extending our meeting invitations to all members of the care team, not just prescribing providers. We know that those nurses, MAs, other members of the team, embedded behavioral health, they're just as critical and important to patient care. So ensuring that they were part of the conversation and on those meetings was critical to ensure that the education we were providing was still getting out to all those pockets of the state. The other was creating a resource repository, as we spoke to earlier, that can be accessed asynchronously. So if you're not able to attend the call, you can still access the resources and the materials that would support you in providing MOUD treatment. And then we also offered individualized training and technical assistance sessions for members of the team not able to attend monthly meetings, but who may have sort of pressing conversations off cycle from those monthly meetings. And then the other challenge that we faced was limited utilization of extended release buprenorphine across Maine. When we started out with this program last year, we were hoping to really focus on extended release buprenorphine. We found that some of the administrative barriers and the reimbursement challenges of that particular formulation made the program offerings that we were offering not as applicable to the folks that we were engaging with. So we created policy and procedure templates tailored to those specific barriers to extended release buprenorphine administration. But then we also expanded the scope of our programming to include those more common low barrier formulations of MOD to sort of meet providers where they were at. Next slide, please. Some successes. We're lucky in Maine to have a pretty well-connected and robust opioid response and recovery community. We felt that we served as a platform for those rural healthcare providers who may feel isolated, siloed in their smaller rural communities to share their experiences and learn from one another on best practices in treating OUD. We also provided a toolkit, thanks to this program, for rural health centers looking to administer low barrier MOUD, inclusive of extended release buprenorphine when the time comes, when it's a little bit more prevalent in our state, that will continue to benefit our community and beyond for years to come. And then one of our sort of anecdotal successes is that we've supported at least one practice participant thus far in achieving the necessary certification to supply and administer extended release buprenorphine in their practice. And they've, as far as we know, initiated 3 patients on extended release buprenorphine. We, as I mentioned previously, had providers from 9 practices throughout the state, and we reviewed 12 cases and had sort of that shared discussion around the program with our participants. Next slide, please. Okay, I'm a little bit ahead of schedule, but I think that's good for the first presentation. If you have any questions for me, my contact information is on this slide, and I would also encourage you to put questions in the chat. I'll be on for the rest of the webinar, so as they arise, please let me know.
Great, thank you, Katie. And next we'll go over to Janelle.
Great, thanks Josh. Welcome everybody. My name is Janelle Lewis. I'm the Director of Leadership Development for the Hanley Center based in Maine. And we offered what we call our Provider Executive Leadership Institute course in Aroostook County, Maine. Those are real pictures, but this is a rural county up in northern Maine. This is who we are. We're a small nonprofit based in Maine, and we focus on developing health and healthcare leaders with a variety of trainings. And this is our vision, and this is our values. Next slide. For this particular cohort, we were able to have Cary Medical Center, Holton Regional Hospital, Northern Light, Northern Maine Medical Center participate. So we started with 15 participants with 5 partner organizations. And we are fortunate to have 3 incredible faculty for this particular cohort. We had Jan Kierce, who's an incredible facilitator and has been working with health and healthcare leaders for a number of years now and has been doing a terrific job with this particular cohort. These are the core competencies that we wanted to make sure that we share with this cohort to broaden their leadership development, and they include systems awareness, learning how to be a better at strategy, better understanding the value and input of healthcare trends. Self-awareness is a huge part of this. We do MBTI and strength finders within this. We also want to help develop their interpersonal skills as well as their business management skills. Another important part is how they can be better at facilitating teamwork and collaboration amongst their team. And then finally, we end with change management, which is a core part of what they are learning as well throughout all of these core competencies. We wanted to include some session feedback here. I guess we would call this some of our successes. Individuals really enjoyed the hands-on approach and talking in about different topics during the sessions. Part of a tenet of the Hanley Center is that we're not only teaching emerging leaders as well as established leaders these skills, but that they're also networking and connecting with other individuals, with not only within their regions, but across the state. We believe that networking only enhances your leadership skills. As you can see from here, they enjoyed the group activities. They like to be able to talk to other people, again, interacting with others, and they found this engaging and relevant and thought-provoking. And we really appreciated this feedback about the interactivity, because that is really important in our rural areas where so many individuals are working in isolation and in a siloed atmosphere. So we were excited that we were able to connect these providers. Here's what we learned. Here are the challenges. And we started this cohort knowing that these would be challenges because we struggled for recruitment, even though there was no cost to these individuals. Capacity with our rural providers is a real issue in that they agreed to be part of this cohort and were excited about it, but couldn't attend. We've had a fair amount of providers who couldn't come just because there was simply no coverage in their particular practice or their particular team, so they could not leave their patients. Location, again, has been a challenge. Maine is small, but we're spread out. So as an example, if somebody's on call, they can only be about 45 minutes away from where they need to report back if they're on call, and that was a challenge. So if they were on call, they couldn't come to this particular session. And then modality, we heard from many participants that they would have appreciated a hybrid component to this course, meaning that some individuals could come in virtually while some others were in the room. And we fundamentally don't do that because it doesn't create the atmosphere of connectivity and networking that we think is really important. However, what we did learn is that if we were to do this again, what we might do is make all of them virtual so that everybody is in the same room, so to speak, and that would have made a difference in attendance by far. And that's it. This is who we are. Our information is here, and Judy Ann is our executive director. I did see a question come in through chat. Josh, did you want me to answer that, or was that
Yeah.
specific to me?
I'm unaware. Tom, can you provide insight into that?
Sure. The question was, Janelle, what was the time commitment for the project?
Well, it's still happening actually. So it is a series of 6 sessions that have gone over not quite a year, and our last and final session is next month. No, in November. In each session ran from 2 to 9. And one of the things we did 2 p.m. to 9 p.m. And one of the things in creating this program that we were really intentional about was talking to the leaders at these particular hospitals and medical centers that we worked with to really find that best time. And we determined that after lunch, that would be ideal because they could have had most of their patient engagement time in the morning and afternoon. And then that after 5, from 5 on, made a lot of sense. What we do provide, and is really important, is we feed them. So they come at 2, we start, and then we have a pretty reasonable break for lunch, for dinner. And part of that intentionality around that as well is, again, that bringing those individuals together to not only learn, but to have that downtime to connect and to be able to talk to one another. So yeah, it's been over, I would say, over the course of a year, essentially, and they meet from 2 to 9 once a month. And then we have an intersession, which is virtual, and that intersession is 90 minutes. So they have these long sessions and then these virtual intersessions. And there's another question.
Great, Janelle. We might look at the other question at the
Okay.
end of the presentation. So perfect.
Wonderful. Thank you.
Yes, thank you. We'll transition over to Ed.
I want to thank Janelle for the gratuitous segue above food. So Amanuset Community Health Services, for context, is in the northern part of New Hampshire in White Mountains. There are 26 towns, 30,000 residents, and ACHS has 5 care delivery sites from as far south as Warren up through Woodsville, Littleton, Franconia, and Whitefield. So we can go to the next slide, please. So food is medicine, or food as medicine, is actually a national framework, in part supported out of the White House initiative. And when we look at roughly the 10,000 patients we serve, they sometimes have a variety of health-related issues such as diabetes or hypertension, and historically a referral to a nutritionist or a registered dietitian is warranted. And as we reflected on this, I will never have enough of those professions or enough money to work with the individuals who could benefit and think about food as medicine. So the construct is to get out into the community with a portable teaching kitchen. And when we reflect on our experiences currently or growing up, no matter where we were in our own home or other homes, it's hard to keep people out of the kitchen. This is where people migrate to. And there's a certain independence of whether the culture, the ethnicity, or anything else that people tend to hone in around food. It seems to be a human condition. It's what we do. So when we look at that, we realize that we spend a lot of time with providing individuals with paper. We talk about food. And for those of us who we can talk about skiing, or we can put the skis on and go ski. We can talk about sailing, or we can actually hop on a boat and sail. So we thought it was important to demystify cooking and make it more accessible as an experience you can smell it, you can see it, you can taste it. And that is a marked difference from handouts. And I, for one, am a visual learner. If I pick up a recipe, autumn coussoulet, which I did because someone shared it with me. If you gave me a recipe at autumn coussoulet, I'm not certain I would have done anything with it, truthfully. But once I tasted it, I'm like, yeah, I want to make that at home. I also realized it wasn't difficult. So can we have the next slide, please? So I wax a little bit Simon Sinek. I encourage people to go look at that. And I think about, what is the why for food as medicine? As you look through these slides, my hypothesis is health and wellness, why it's important and why food is important, is really an attribute of relationships and or experiences. We want to be there for our daughter's wedding. We want to be there for our child's graduation. We want to teach our grandchildren how to fly fish, how to knit. We like to do crossword puzzles with our friends. So I think that is an important facet of health and wellness in general, and food in specific. The other why, when I think about food, is it's an intergenerational opportunity. When we think about rural and northern New England, there's a fair amount of social isolation. So coming together over a meal addresses social isolation. So I think when we think about food, we probably have our own personal why proposition, like what's the purpose? And so we can move to the next slide, please. So this gets to the how, and I reflected a little bit on the necessity of providing people with information, and making it more accessible gets to how all can we provide this experience. So when we think about the how, a lot of us learn in multimodality. It's hands-on and experiential. When we go to a grocery store, most of them are designed the same. There's the vibrant colors of the food and the vegetables. There's the smells of the delicatessen and the bakery. And those hit us all, and you're probably all starting to get a little bit hungry now as a result of that. So we wanted people to have an experience, to come together around a meal. And the ideal is that we wanted to have food from prep to plate in fewer than 30 minutes. We want to be sensitive to food pantries, feed pantries, commodity surplus food, WIC and SNAP. How do we take all those sorts of different sorts of resources and enable people to have an understanding of, well, what do I do with a bag of dry lentils, which I can tell you often sits in the food pantry almost for multiple generations. I haven't checked the date on some of them, but nobody knows what to do with them. So let's have a meal together, share a meal, and see that it's not really that hard. Next slide, please. So this is the what. And without further ado, I'm going to go to the next slide because there's a video. So I'm going to ask you, this is Jose Bonilla, and you're going to get a taste, pun intended, of what it is we do, and you'll get a sense of what the Teaching Food Kitchen looks like. So if you could play the video, please, I thank you.
Hello, welcome. My name is Jose Bonilla. You may recognize me from the co-op a few years ago. I am also partner owner with my wife Casey for Bonilla Bread up in Bethlehem, New Hampshire. So I love to cook, and today we're gonna make a ham and Swiss omelet wrap. So with this, you only need 5 ingredients. You have a low sodium ham, some baby spinach, a couple of eggs, and some Swiss cheese. You could vary this if you don't do the ham. If you're a vegetarian, add some more veggies to it. If the Swiss cheese is not your thing, do some cheddar, you could do some provolone, anything you'd like, and make it your own. And it's a very simple, easy, low carb meal. Now we're gonna chop up this ham. You can roll it up, slice it that way, and we're just gonna chop it after that. Mind your fingers, go nice and slow. I've been doing this for many years, so chopping. I could do it while I'm not looking, but we're not gonna try those skills today. We're gonna make sure everything is great. So, got my ham in there. And it's about 1 ounce of ham and 1 ounce of cheese. So that's like a slice of each. If you're into measuring that kind of stuff, make sure you get just the right amount in here. You could add more eggs to this, make it a bigger meal if you got some company. You know, the kids had their friends stay over. It's a cool breakfast for the kids, teenagers, adults alike. Spinach, we're just gonna rough chop this. It reminds me of basil. Basil, you tend to just stack it up and then roll it and then chop it. But we're just gonna stack it a little bit, chop it that way, go this way, just like that. That's called rough chopping. Mind your fingers, keep your hand on top of the knife if you're doing that. There we go. Throw it all in there. That oil looks like it's just about ready in the pan. So mix this guy up, and we're gonna pour all this in at the same time. We're gonna make an omelet out of it, so we're not gonna move it around. We're all just gonna throw it in and spread it out. And we're gonna let that cook right there. You wanna wait till about the time that all the way around the edges are dried up. They're cooked. And around that time, we're gonna put our tortilla. Got these tomorrows, carb-wise multi-grain wraps. These are great. It's spinach, ham. And notice I didn't put any salt in this. It's because of the saltiness of the ham, even though it's low sodium, you just get that natural salt from the ham. It'll be nice. All right, so now we're gonna get this guy off of here. Egg is cooked. Slide it right into a plate. Bigger plate if you need it. Let's turn our burner off. Now this is gonna be pretty hot. Just came off the hot plate, right? Off the hot pan, I'm sorry. And now he's gonna roll it up. I'm used to dealing with hot things, so I'm just gonna roll it up. But I would suggest waiting a few minutes before you roll it up yourselves. And that's it. Get that at the edge of it. You want to just keep that down and pinched underneath, so you can let it cool down like that. And we're going to cut that in half. There you have it. That is a ham and Swiss omelet wrap. Thank you for your time. Enjoy making that. Have a great day.
So thank you for sharing that. And I only have a few seconds left. So what I want to note is that if you were there, I'm going to ask you, did you enjoy it? And as a footnote, we're going to lightly touch on the low carb for people who have diabetes. We're going to lightly touch on the fact that it's low sodium as a footnote, not a headline. So we're going to be subtle in our approach. So that's what we have. Thank you for allowing me to present it. Have a great day.
Thank you very much, Ed. And we will transition over to Lynn.
Hi, everyone. Thanks for joining today. My name is Lynn Chow, and I'm the Pediatric Oral Health Project Coordinator here at Dartmouth Health. And we're going to be talking about silver diamine fluoride in primary care. So I'm also a nurse practitioner, and I've been practicing for about 27 years in rural health clinics, family practice, pediatrics. And I think what drew me to this project was the seeing the burden of early childhood caries and care, seeing kids during well-checked visits or an episodic visit, and they come in and they have cavities. So in the difficulty in trying to get them into a dental home. So for certain reasons, whether it be insurance issues, state insurance, a lot of dental clinics don't take, just getting, in to see a dentist can be a long wait time, and then the lack of providers in the area. So this really interests me. And I think in primary care, we can really offer our patients something, a tool until they can get in to see a dental provider. Pediatricians and family practitioners see children about 10 times in the first 2 years of life. So they're really seeing these children a lot more often than a dentist will, which may start at age 3, 4, or 5. Ideally, they should be in by age 1, but a lot of times the dentists don't see them as soon as we do. Next slide, please. So the origin came out of the Dartmouth Health Community Needs Assessment in 2022. It was found to have a care gap in oral health, both in pediatrics and adults. We have grant funding through HRSA in Northern Borders region. We collaborated with Vermont Department of Oral Health in this project. And it's a pilot project to train medical providers, pediatricians, family practitioners, how to apply silver-diamine fluoride in primary care settings in order to arrest dental decay. So kids 0 through 5, we're training providers. Training is provided by a registered dental hygienist and myself, and we do Tracy will do one didactic and then a hands-on training. Next slide, please. So these are the practices that we've been training. We have about 8. 6 of them are pediatric practices. 1 was family practice, and then the other one was Dartmouth Health Moms in Recovery, so moms who are having issues with substance use. So that would be applied in an adult population where we know that there's a high need for adults that have substance use issues. We're mainly training MDs, nurse practitioners, DOs, and PAs. Also did some outreach to our federally qualified health centers, so we're working with them as well. Next slide. So this is just an example of what it looks like, the technique where you take silver-diamine, which is a bluish liquid, and you apply it to the cavity so you can actually see the cavity on the tooth. You have a little micro brush, you dunk it in, and you apply it for about 10 to 60 seconds. So it can be done in a clinic. Next slide. And this is our dental hygienist, Tracy. She is working with a group in Bradford, and they are doing, this is the second session, they're doing the hands-on application of the silver-diamine. So she brought in some tooth models, and they could actually apply the SDF onto the tooth model. Next slide. Another provider practicing on the hands-on session with SDF. Next slide. So some of the barriers that we found in terms of engagement in the practices that we were doing some outreach to, primarily for New Hampshire, payment is a barrier since New Hampshire Medicaid does not cover silver-diamine fluoride in medical practices where Vermont Medicaid does. Other practices had some issues with asking their staff to do more, applying, another service line or asking them to do more in an already busy visit. Some practices had some hesitance moving forward because there really, up until recently, were no medical guidelines in terms of how to apply silver-diamine in a medical setting. So the American Academy of Pediatrics just in July came out with some guidance around that. So hopefully that will motivate more providers in order to do this. Unfamiliarity with oral health. We did find this in some folks. I'm not a dentist. I wasn't trained as a dentist. I'm not sure of my assessment skills. So it is a learning curve. And we know that medical and dental have been siloed for so long. It's just getting used to that. Pediatricians and family practitioners obviously do oral health assessments. They do anticipatory guidance around dental care, nutrition, and development. And then the last one is beyond that, workflow issues, EMR, how do you bill, how do you code? So those all came into play. Next slide. So this is the progress. We've had 2 practices actually apply SDF, Upper Valley Pediatrics, which is a small rural health pediatric practice, and then Dartmouth Health, the Purple Pod. They've applied it on some some patients there. There have been challenges, with terms of the Purple Pod trying to identify their high-risk patients and how to get them in and how to apply this procedure. Other clinics having issues with, trying to get things through organizational processes and committees can take longer than expected. The last few clinics there are pretty newly trained, so they are in the process of sort of getting this on board and getting things organized. Next slide. Sustainability and education. We developed a 3-session Project ECHO on silverdiamine pediatric oral health assessment. The first, a dentist presented in the second one, application of silverdiamine, and then integration into practice. And that is the link to the website on the DH website. Next slide. And this just shows what the Project ECHO looked like. You can see the speaker, you can see the presentation, and then the sessions up in the right-hand corner. So that is still available for folks. Next slide. And then we also developed the Pediatric Silverdiamine Fluoride Toolkit. We compiled forms, policies, procedures, videos. We collaborated with Vermont Department of Oral Health. Next slide. And this is what it looks like. That's the title page, and then some of the pages in. And this is also available on the DH website through Center for Advancing Rural Health Equity. And I can share that link. So this toolkit is available online. Next slide. And part of my role, it helped to integrate, help providers integrate into care, the silverdiamine. So looking at things like workflow, consent forms, supplies, how to organize that, how to train your staff, and then identifying high-risk patients, billing, Medicaid, and then lastly, developing a referral process for dental home or dental dentist, a local dentist. And next slide. So we talked about some of these. One of the strategies for barrier for the New Hampshire folks is to look at, instead of a different way of coding it, instead of a well check, doing it as a evaluation and management visit, like a 99213 or a 99214. And then looking at exclusion inclusion criteria for the folks you want to treat. The AAP guidance has been really helpful in terms of, support, as well as the toolkit and the Project ECHO that is available. And then what we're going to be doing in November is we're going to try to get all of the folks, all of the practices that we trained, all 8 of them, back on a webinar and to talk about their progress, strategies, barriers, things that worked, things that didn't work. So we're hopefully doing that in November. And I think that is it. If anyone has questions, I can take them now or after the presentation.
Yeah, thank you very much, Lynn. And we'll save questions for the end of the presentation. And next, we'll go over to Jennifer.
Good afternoon. My name is Jennifer Carpenter. I am the practice nurse manager for BMH Orthopedics and Sports Medicine, as well as BMH Podiatry, both affiliated with Brattleboro Memorial Hospital in Brattleboro, Vermont. I'm one of the co-creators of our mobile integrated healthcare program. Next. Our program is a collaborative project between our hospital and Rescue Inc., one of our local EMS providers. It was initially designed as a pilot program. We started with a small controlled group of our orthopedic total joint patients. The program, we knew we would eventually want to expand it into additional service lines, such as COPD, CHF, diabetes, but starting with our total joint patients gave us a nice controlled group to start with. It provides an in-home assessment for our patients, as well as an external support patients system for the patients and their caregivers once they're discharged home. The program is available 24/7, 365 days a year, with a dedicated phone line that is responded to by trained MIH providers. It's the first program of its kind in the state of Vermont. It's currently only available for Vermont residents, but we are working on and shortly will be expanding into New Hampshire for our patients that reside over there. Next. In the early stages of our go live, we worked really hard to disseminate all of the information out, not only to our patients, but also to all of the staff that care for our total joint patients, to our organizational leadership, our board members, and the community at large, so that everybody had a great understanding of what the program was, its purpose, its goals. Next. Here's some great pictures that we had an article published in one of our local news sources. The first picture highlights the exceptional education that we already provide to our patients. And then the second picture is showing one of our MIH providers in the patient's home, reinforcing that education again, but also checking in on them at key intervals post-op, as well as initially pre-op. Next. Our primary goals for the program sought to improve patient health outcomes, decrease hospital readmissions, improve patient and caregiver experiences, and ultimately to reduce the total cost of care. Secondary goals look to provide a safe transition into the home after discharge, as well as to reduce preventable and/or unnecessary office and ER visits. Our goals nicely will transcend into other service lines as we continue exploring expansion. Next. Our training program for our MIH providers was pretty extensive and is ongoing. It's important to us that the MIH providers had a solid baseline and understanding of our total joint replacement program, since they were going to be an extension of us continuing to provide that exceptional care. Consistency in education and messaging is really important to the patient's overall success, and we wanted to ensure that they were able to reinforce the same education that we were already providing to them. The training consisted of shadowing in the OR, so they were able to observe at least one of each of the joint replacements that we do, hip, knees, and shoulders. This gave them a little bit of a glimpse into what the patient experiences, which helps on the backside when they're now home with the patients. They also had time set up where they shadowed on the MS2 floor, our post-operative floor. They shadowed with nurses and physical therapy so that they could learn the normals and abnormals of what to expect in post-operative total joint care. They shadowed in our orthopedic outpatient clinic with our clinicians to reinforce the education again that we're providing, to see what the patients are doing at their 2-week post-op visits, and just continue building that knowledge base. And then we also set up some specific training modules in our online education system referred to as Elsevier. We will update these modules on a continual basis, and they'll be required to do these modules annually. And then lastly, we ensure that there's a direct line of communication for all of our MIH providers to reach out to the clinical staff and or the clinicians that are on call, should they have any questions or concerns, or if it's the first time they're hearing a specific question from a patient. We didn't want them to be out there wondering how to handle that. They know to call us. So that's been a great avenue. Next. So to get the ball rolling, after the decision to have surgery has been made, all of our total joint patients meet with our total joint nurse navigator. She then discusses the program in greater depth, and if they opt in, they sign consent. We then send the referral off to MIH, who coordinates an in-home visit roughly 10 to 14 days pre-op. While they're in the home doing that first initial visit, they're doing a safety assessment, looking for throw rugs, stairs, what kind of equipment they might need and where they could get it. They're also assessing whether or not they've picked up their post-op pain medications or anticoagulants that they're required to take. They're confirming ride arrangements for pre and post surgery. And again, they're reviewing education with the patient and their home support team. On the day of discharge from the hospital, we coordinate roughly the time that the patient will be arriving home so that MIH can meet them at their home and ensure that they're able to safely transfer stairs, that they have a place where they can be comfortable sitting, recovering, that they have their ice, when to take post-op meds, what those meds should look like, and then the phone number, reinforcing what number for them to call so that should they have any questions or concerns, they first call MIH with those needs. At 1 week post-op, all of our patients get a phone call. For our total need patients that are a little bit more high need, they get a in-home visit where we're assessing range of motion, doing wound care with them, answering any questions or concerns that they may have. And then there is no limit on additional phone calls or home visits as determined. If we determine in the clinic that we really are concerned about range of motion, we call MIH, we set up another in-home visit for them. Next. So some of the successes that we've experienced in our first 10 months has been a reduced call volume to our orthopedic clinic, as well as reduced call volume to our on-call clinicians after hours. We've seen a reduced number of ER visits and 911 utilization. We've been able to reinforce education with patients, improved in-home patient safety. We didn't really have, that eye in the home prior to, so that has really reduced some of the risks that patients might experience at home. Increased patient and staff satisfaction. And it also has given us a great opportunity to collaborate with other community partners that we work with and that work with our patient population. Just some numbers, we know that the average cost for at least this initial go live was roughly $1,100 per patient. Taking into consideration what a readmission cost would be, which is roughly $15,000, one can see where this program has just wonderful advantages. Next. Here's a look at the data. We've enrolled 142 patients in since go live. 351 of those have resulted in visits, whether it be pre-op or post, or just the phone calls. We've had 41 patient-initiated calls. Those would be calls that would have otherwise come to us, or patients would have gone directly to an emergency room with questions. 20 of those have been telehealth visits. 19 have resulted in a home visit. We did have one patient that we didn't even go to the home visit. We knew that they were having a cardiac event, and so we were able to initiate 911 for them. And then 2 visits once in the home resulted in a need for transport to the PD. Next. Some of the challenges that we've experienced and continue to work through initially was patient buy-in. Patients were a little hesitant to have us come into their home and make those initial evaluations. We worked on our verbiage and the education that we provided to the patients and have really overcome that challenge. Technology integration continues to be one of our more significant challenges right now, and we're working on sustainability funding. Next. We'll scroll through this, but I've been fortunate to be able to partner with a number of other organizational leaders within the organization to help as we expand. Next. We are moving on and expanding into COPD as our next service line with a targeted go live of November. We're hoping to enroll 120 COPD patients in our first year. And then we'll continue with our orthopedic population. This is a glimpse of the COPD action plan. We will be adding one more level in here, orange. The goal will be to keep patients, when they hit that yellow to orange level, that's when MIH will be initiated, reducing the red zone and further readmissions. And then we'll have 2 patient pathways, one where patients will be enrolled after an inpatient visit. And then next slide shows our workflow from the outpatient side. If they're seen in the clinic, we can initiate the pathway for enrollment here. Thank you so much. This is a bird's eye view of our mobile integrated healthcare. Thank you.
Great. Thank you so much, Jennifer. And we'll roll right into Joanna's presentation.
Thank you. I'm Joanna Loomis. I am with Fort Drum Regional Health Planning Organization, and thank you for the opportunity. Excited to share a little bit about our project to try and improve primary care access and experience in our region. Next slide. So we can kind of fly through this, but yeah, I'll give kind of what is it that we set out to do? What did we do? What are the outcomes and next steps? Next slide. Yep. Perfect. So just to give you a sense of where we are Fort Drum Regional Health Planning Organization. We are a nonprofit. However, we're not a clinical entity ourselves. Instead, we work with partners that are clinical, primary care, behavioral care, and social care in our region, and work together to collaborate and sort of collectively, promote innovative best practices in the region. So you can see we are in upstate New York, bordering Canada and the Adirondack Mountains. If you scroll again, you should see that we are, sorry, next click. Thank you. We are largely, we have a significant population that is insured by Medicaid, Medicare, or are uninsured, which is another way of saying it's, fairly high, low income population, elderly and or disabled. We are considered a health professional shortage area and have some health disparities that we're experiencing in our region. I would say that in terms of racial and ethnic diversity, we're not particularly diverse in that sense. We are mostly a white population, but the diversity comes more from our socioeconomic status. So we do have more significant rates of poverty, and obviously the intersection between poverty and health outcomes is very significant. And that's what really kind of fueled this project. Next click. So really what this project is doing is seeking to better understand the people in our region on a kind of pop health level as well as an individual level, and then better meet their needs. And we're doing this through 3 main activities. I'll get into all of that in the next few slides. Next click is that we have leveraged a network of 31 partners across the kind of continuum. And final click should be our target population, which is low income, disabled, and or elderly rural individuals. Next slide. So 4 main objectives, all linked, but the first really is how can we support staff in the region to better understand the populations they serve and better meet those populations' needs. And so we were trying to do that through promoting health literacy, cultural competency, and socioeconomic diversity trainings, and then prompting the trainees to actually identify and then implement actions as a result of those trainings. The next main area is making sure that we know more about the people we serve by doing standardized social determinant of health screenings, so we can find out more about what are your housing needs, what are your transportation needs, food needs, etc. And then depending on their answers, making referrals as appropriate. And then finally, finding out more about the population on sort of a general pop health level by doing a massive community health survey among our residents that touches on all of these things. Next slide. So what did we do in terms of the actual trainings? We held 8 trainings, and they were ranged between 3 and 5 hours. They were all in person, and they were held at various locations throughout our region so that we could best meet our partners where they were at. Next slide. And these are just some pictures of the trainings, just to give you a sense of who attended, but they were well attended. And I think having them in person was really important. We saw some really good engagement that is hard to replicate on a virtual, setting. Next slide. It's another training. Next slide. Yep. And next slide. Thank you. So what happened? We trained 169 staff, and that was more than our goal. We were super happy with that result. And I would note that it was a mix of clinical and non-clinical staff. I think it was actually wonderful to have a good mix of people in the room because you learn from each other and each other's perspectives. Next click. And next click. And next one. Perfect. And in addition to those in-person trainings, we also did record about a 1-hour training. This is because we'd love to keep having these in-person trainings every year, ideally. But staff turnover happens, and these are the types of trainings that you can do them multiple times a year, and the material isn't stale. It's good to keep engaging with them over and over again. It's not a bad thing. So we did do a recording, and we'll be sharing that with our partners, so they can at least, tide some of their staff by into the next year's trainings. Next slide. And so here's some of the things that people said they wanted to do as a result of the trainings. This is really the meat of that, right? It's what are they going to do? So paperwork was a theme. How can we consolidate paperwork and reduce the reading level for patients? How can we incorporate more same-day appointments or even allow walk-ins, really pushing the envelope on patient-centeredness? Creating a patient advisory committee, so you're getting structured feedback from the people you serve about their services and reimbursing them or giving them some nominal kind of gift when they do so. Creating a culture of encouraging questions from patients and clients, and studying your visit life cycle as well. Next slide. Oh, and tackling no-shows, of course. Proactively addressing patient barriers. Next slide. And furthermore, doing things like providing, some tangible assistance immediately if someone does say they have a need, providing hygiene kits if they need it, translation services. Next slide. So that was a training piece. There's so much more there, but kind of in the sake of time, we'll move on to the social determinant of health screening piece. So our partners did select a standardized screening tool. It's based on the CMS Accountable Healthcare Community Screening Tool. They conducted over 1,600 screenings during the grant year, but we want to get more sophisticated in the future, make sure that our partners have that, for example, integrated in their EHR. That way you can run reports off of it. Some of our partners are still just administering the screen using a piece of paper that's scanned into the patient chart. Doesn't really allow for good tracking. Next slide. This is just a screenshot of the actual screener. That's kind of part one. Part two is on the next slide. And next slide. And the final piece was that community health survey. So if you click through, sorry, I made it all broken up, Josh. But we got 1,800 adult respondents, a really low margin of error, which is good. Next slide. So some of the high level takeaways is that a vast majority of people indicate they have someone that they feel is their personal provider, but only about half feel that their values are always respected. That is a significant decrease from 2016, so we don't want to see that happening. When you expand that window to include always or most of the time, it does increase to 86%, but there's some disparities, notably among the Black, Indigenous, and people of color kind of subgroup at 77%. These next few are really important. I want to take a moment with these, which is it's showing that there is some correlation between feeling respected by your provider and then engaging in recommended preventive care. So among females aged 40 to 75, who in a separate question reported feeling respected by their provider, 86% of them had a recent mammogram versus only 71% who reported they did not feel respected. Next click is going to show you an even wider difference between colon cancer screening. So people aged 45 to 75 who said they were respected, 82% of them had a colorectal cancer screen in the last 10 years versus only 64% who didn't feel respected. Next slide. Again, it doesn't show causation, but it does show correlation. Again, I'm running out of time, but I'm almost done, so I'll keep it quick. roughly 1 in 3 experience challenges accessing primary care. You can see some notable disparities there. Long wait time is one of the most significant challenges. Next slide. And there's some transportation, barriers overall, not just with healthcare, and definitely some housing. Next slide. Love that music. So what are we doing next? We're going to keep training staff, as I mentioned. We want to keep following up with partners on those action items and continue to work on proliferating those social determinant screens, as well as getting more sophisticated about the data collection. And then continuing the conversation of sharing those survey results with partners. And I think that brings us to the end. Thanks so much.
Great. Thank you so much, Joanna. And we will go into the next presentation and we'll turn it over to Elizabeth.
Hi, everybody. My name is Elizabeth Stiles. I'm the Behavioral Health Operations Manager at St. Lawrence Health System for our outpatient services. Our project was the Peer Support Network Program. Next slide. We're going to skip a couple here. So this is just our values and our purpose. You can go to the next slide. We are way up here in St. Lawrence County, right up by Canada, just like Joanna said. So we're in a relatively similar area up here. So you can go to the next slide. Okay, so our objectives. Our objectives are certified peer recovery advocates, job satisfaction and retention, as well as improving and enhancing access to healthcare. We really want to offer individuals that are receiving our substance use disorder or behavioral health services access to secure peers who are able to address our social determinant of health, as well as have the ability to address immediate needs on the spot. Next slide. So this is kind of just repeating the prior slide. I think it's noteworthy here to say, peer support is a newer mechanism, a newer position in our area, and there's not much for compensation standards or marketplace data. So we currently have a salary that is $22,500 less than the median household income for our county. Half of our staff is employed with an additional job to help to offset the salary deficit. And then in addition, our peers are struggling with, managing their own recovery, dealing with difficult, unpredictable, emotional, challenging situations. So they're often the first person to respond when a patient contacts us and is needing something right away. Lack of resources to fill immediate needs. So we did find that our peers were actually spending their own money to purchase supplies for our patients when they were unable to use another community resource to address that need in an immediate time. Peers also might face stigma and discrimination on their own history of addiction and mental health, and high levels of burnout, compassion fatigue, and then also limited opportunities for education and professional development. Next slide, please. So potential outcomes. So basically a decrease in peer support services would really lead to a loss of support from somebody with lived experience and a negative overall effect of recovery outcomes. So this person, may be the only person that one of our patients is willing to speak to, really when they're starting their journey in their recovery. So often these staff members will meet them in the community. They might meet them in jail, hospital, inpatient, so all over the place. Next slide. So our overview here, so our target population is pregnant and postpartum people, as well as transitional youth, aging adults, individuals with TBIs or developmental disabilities, individuals that are recently incarcerated, returning to the community, as well as people who are, transitioning from maybe an inpatient detox or inpatient rehab. Again, we're in St. Lawrence County. We are the largest county by land. However, only 5 of our populations have over 5,000 people. So just to kind of give you the gist of how small we are. Next. So this is just a quick overview. I won't go into all of this, but regarding client and treatment system factors and how peer support can address each of those. So the main ones that we find that we're able to address are social isolation, disconnection from services, and then overburdened providers. We do this as peers by being a role model, as well as case management, and focusing on meaningful life roles, as well as reintegration back into our community. Next slide, please. Next slide. Sorry. So our first goal is recruiting and retaining peer staff. Next slide. So I'm just going to kind of condense this. So basically what we wanted to do was identify what our staff preferences were as far as areas of interest for education and additional training and development opportunities. We wanted to provide those things to them, as well as a retention bonus. And we provided that based on their completion of staff surveys, just so we could really try to measure this as we went on. And also to create access to funds for patient needs. Next slide. Our second goal is to identify the unique access problems, as well as healthcare and social needs for our target population. Next slide. So we were able to implement the Recovery Capital Index, which is a scientifically validated survey that provides really a multidimensional measure of well-being, regardless of what treatment the person is getting. And it really includes all experiences. So this has been a really great tool for us to utilize as far as helping to measure patient outcomes, because that's difficult when you are looking at substance use disorder and behavioral health. Next slide, please. Next slide. Sorry. So challenges and barriers. So I'm just going to kind of condense this down. So our major challenges were lack of qualified applicants, compensation rates, obviously, inconsistent policy for supervision requirements and needs. So again, this was a newer position. So we're learning really as we go what the staff is needing, but we're doing that by asking them and continuing to kind of, change what we're doing weekly and monthly as far as educations and supervision. And then also real-time access to funding and availability of whatever the needs are geographically across the county. So our peers are often so spread out that it's very difficult to go to one side of the county if you need to get an item. So that was another pretty significant challenge. Next slide, please. You can go to the next slide, sorry. So just some impact and successes. So here's a few things that we were able to do. So we did create a giving closet in all of our outpatient locations. And we've been able to give diapers, wipes, formula to over 40 families. We've been able to provide local families with over 500 items to assist them with their immediate needs. Those include things like clothing, undergarments, their food, household products. So we were finding that people weren't able to afford like trash bags and stuff, which, led to an infection control issue. Medication lock boxes for safety, homelessness kits, gas cards. We were also able to help our patients as far as affording their medication before they were insured or if they were underinsured. A lot of safety equipment and harm reduction supplies. And we were also able to purchase a bulk amount of cell phones to help our patients who did not qualify for the free phones through social services to help them to continue on with their treatment. Next slide, please. Just a couple patient stories. Can you go to the next slide? Okay, so impact on our peer employees. So we were able to help our peers really identify what their training wants and needs were. So some of the trainings that were completed were recovery coaching and justice settings, as well as the emergency department. Coach revision, so to really help with supervision and kind of navigating that. Women in recovery certification, and then also we all have the opportunity to attend the New York State Recovery Conference in Albany. let's see here, financial assistant. Oh, we were able to also employ 2 of our previous graduates from our maternal wraparound program, which is a program for pregnant women addicted to opioids. We also were able to secure a NADAC membership for all of our peer staff, provide peer stipends, as well as establish scheduled supervision weekly with a psychologist. Next slide. So our job satisfaction results. So this is the final survey. So 100% of our peer workers strongly agree that having access to immediate funds really impacts their job satisfaction in a positive way. Compensation rates are affecting their likelihood to remain in their current position in a negative way. Those are all 100%, as well as a negative impact when there is a lack of resources as a barrier to care. Our job satisfaction score in our initial survey in 2023 was a 3.8 out of 5, and 2024 we're at 4.2 out of 5. Next slide. So this is just, oh, next slide, sorry. This is our project takeaways. So the major takeaways of this are providing our peer staff with comprehensive onboarding and training, regular supervision and support, and fostering a really supportive work environment. We also want to allow our peers to have feedback mechanisms. So to be able to talk about the opportunities, you know, that they've had successes or the impact that they've made on others, and really acknowledge and celebrate the contributions that they're making to our patients. Next slide. And additionally, career development opportunities. So we really want to provide our peer staff with opportunities for growth and fair compensation and benefits. So offering incentives for performance, longevity, and additional responsibilities, and feedback mechanisms. So again, really want to make sure that their voices are heard through our organization, as again, this is a newer position. So it's been a lot to navigate that, you know, in the different departments and in various places within the community. Next slide.
Right. Well, that concludes our 7 presentations. And now we're going to open it up for some Q&A to the audience. Give folks maybe a minute or 2 to type something into the Q&A. Is there anything, Tom, that's bubbled up?
Yeah, Josh, Jennifer may have answered. Is this for Jennifer? The question is, fantastic program with the MIH. This individual is curious how you see this working with chronic health conditions. Would it be a post-hospitalization service offering? You kind of touched on it, but Jennifer, I don't know if you can expand maybe a little bit.
Sure, I'd be happy to try. So yes, this would be a post-hospital, although there's opportunity where MIH would come in and meet the patient while they were still here, should they be in an inpatient role. But yeah, it would be primarily post-hospitalization, post-outpatient clinic, in an effort to reduce the need for readmissions. They're one of our highest readmission rate population at this time.
Thank you, Jennifer. Josh, nothing else popping up yet in the Q&A. There is one in the chat. Let me just get to that one. Whoops, sorry. And this one is for Lynn. Lynn, it says, are the folks using SDF also applying fluoride varnish for prevention?
Yes, they are. Most of the clinics are using the fluoride varnish as prevention. And then in the technique where you apply the silver diamine fluoride, you actually put the fluoride varnish on top of it. So yes.
Thanks, Lynn.
Great. I just have a general question that anyone of the presenters could certainly feel free to chime in. So I saw a theme that bubbled up, which was community partnerships really played an essential role in the success of your projects. After folks have saw your programs, potentially may want to implement something similar, what advice would you give them looking for these collaborations and initiating similar projects? Anything that could be really helpful here? Feel free, anyone, to just go off of mute and chime in on this.
For us, it was essential for us to have that community collaboration. Obviously, we weren't able to go into the patient's home, and we were kind of filling a void with our EMS. They've really stepped up and enjoyed this new, to go into a patient's home that isn't having an absolute crisis. It's really kind of expanded their skill set. And increase their job satisfaction as well. So the community collaboration has just been a wonderful avenue for us.
Great, thank you, Jennifer.
I think one of the lessons I've learned when I think about, we do a lot of needs assessments and they are important, that relationships matter. That's mostly what we do that's important. The transactional pieces are actually relatively easy once those trusting relationships are in place. Doing things with communities is distinct from doing things to or at them, and there's a receptivity when we do things with communities. So the other piece I've learned and we're starting to look at is there's a lot of assets, resources in our communities. We don't know where they are, and so we're starting to collect like for food, where are all, and then geospatially mapping them in a searchable manner. Because there are some incredible resources that are a few degrees of separation that if you talk to the right people, they can get to the next right person and get you to the resource. And how do we capture that community knowledge, resources, in an easier way to let people find things for themselves. So it's something we're just leaning into. It was an aha moment of like, we spend all this time on needs, but there's incredible resources of resilience and regeneration. We just need to like go find it and have a conversation. So I think walk around, talk to people. It's almost like you're a politician, go and talk to people, listen to them and see what they have to say. I think that would be my recommendation. Spend time in the community outside of our health centers.
Great, thanks, Ed. Yeah, Tom, I think you have your hand up.
Yeah, Josh, we have a question in the chat specifically for Elizabeth. And Elizabeth, you can either I'll read it, but were there other peer recovery programs from other states or locations that helped inform your program creation or changes?
Hi, Kelly. So I kind of, to be honest with you, I hopped online and started researching. So one thing that I did use quite a bit was NADAC, which has a ton of different educations, furthering educations for both the staff, but also as far as supervision. So really to just, try to figure out, I guess, from a higher point of view, where to start. And then once I started talking to all of the staff and really started, questioning them and really pushing them to be honest, was really when I got, the majority of the program idea and thought behind it. So yes, I think that there are some things that exist, but also it's a bit different just because in New York State, we're all in a substance use disorder clinic. So there are also different types of peers, behavioral health, so there's that too. But yes, I would definitely go online and start researching, but NADAC is a really great resource to utilize.
Thanks, Elizabeth.
Right, I have just another general question for the participants as we continue to see if anyone else has a question. What are some of the key factors that will help determine whether or not your projects can be scaled and sustained over time in your rural communities?
I can speak to this one as a program that has been sort of offering this similar education for about 3 years at this point. We found that we had a really strong group when we first started this work that was attending those monthly meetings. And over time, as they became more comfortable with the subject matter and what they were working on and providing MOUD care, there was less of a reliance on those monthly regular meetings and more of a reliance on the asynchronous resources and the sort of supports that they don't have the time or resources in-house to build up. So one of our sustainability measures is really having like an index of like pretty much anything you would need to sustain an MOUD program available at our fingertips that we can just sort of send off. So that was sort of our trigger to sustain this like education and improved access.
Great. Thank you, Katie.
I'll just jump in and say, obviously, we've kind of touched on it, several of us, but how reimbursable are these services, right? And if, I mean, that's key. And do all payers reimburse for it, or, you know, do some not? And how much do they reimburse? And, you know, is there a case that you can make to spread this to other communities and keep it going within your own community or region after the project's done?
Great. Yeah. Ed.
Yeah, the sustainability is always an important factor when and so this is a one-time grant. And so some of the investment is in tangibles that have a long life expectancy, a portable teaching kitchen. So that's something that will reside in the community and be able to be moved 10, 15, 20 years. The other piece to sustainability for us, as you saw the video, moving forward, we will work with the Northern Vermont University, has a videography program. So the students need a valuable something. They're going to go out in the world and someone's going to say, well, tell me about your work. And they can actually go, well, here, let me show you. And similarly, when we looked at the asset inventory in Northern Grafton and Coos counties, we work with Southern New Hampshire University's Masters in Public Health program. And so we get them for a scope limited. They get a capstone project for their master's, which is academically rigorous. And we get a legacy piece of information that we can build upon. So those are two. And the last one is White Mountain Community College has a culinary program. Part of their curriculum has them evaluate a recipe for nutritional content. I'm like, well, that's interesting. And having come from academia, you got to be careful about messing with other people's curriculum because of curriculum committees and accreditation. You got to be careful. So we're able to have them evaluate a recipe. Now they get to come out in the community. We're not quite there yet. Why don't you cook it? And then get people's input on it. We can then have the video that becomes legacy, and it's open to all of you. When we post these out, it's not ours, it's ours. And then thinking about the handout that is heavy visual picture led on visual text to increase the access based on learning styles for this work. So some of it is we're tying in with other community partners, thinking like a Venn diagram of academically rigorous real world solution. You go to a job interview and your show and tell is still out in the world and still adding value. So that's how we've tried to creatively figure out, you know, what do we do when we have no money? How does this live, you know, that I can step back and it has a life of its own and the community has wrapped their hands around it and they're taking some responsibility for it.
Great. Thank you, Ed. Yeah, Tom.
Hey, Josh, we just had another question come into the Q&A, and the question is, how do you work through the frustrations of rural care, i.e. lack of resources, large service area, and not get overwhelmed by how much is needed in the community? We could probably spend another afternoon on that one, but I don't know if any of our panel or sub-awardees want to take a stab at that. How do you not get overwhelmed with the need?
I was taught you eat an elephant one bite at a time. That's kind of the overarching. One of the things is I've spent more and more time, and I love spending time with my healthcare colleagues, but also getting outside of healthcare. Sometimes there's a purview that I'm like, huh, that's interesting. So we have an early childhood development program. We have too few children over too many miles, which is welcome to rural, right? We're using the library system. I have 26 libraries. And so if a child needs a device, call it $100, and the parent can't afford it because they don't have food, we're using interlibrary loan. It's the library of all things health and wellness. So we can leverage interlibrary loan exists. Thank you, Andrew Carnegie, for libraries. And so I have some human resources to deploy closer to the guardian and the child. But I also have resources that can go out into the wild, come back, move to someplace else. So it does require some creativities and an unusual cast of characters that you might never have thought about working with who aren't healthcare specific. And there's resources in the community. You know, I have 10,000 patients. I need to speak to them about what they can contribute. You know, so it's we're gonna have to do this together. It is going to take a community, and you know, one bite at a time. You know.
I'd like to add to that. I totally want to echo what you said as far as, you know, really reaching out to the community and figuring out what all of those resources are and what they can provide you. Oftentimes, you know, we go online and we look, or, you know, you have a pamphlet, but that's not all inclusive. And you can really get creative with a lot of these different community-based resources as far as figuring out and finding what you need. So a lot of creativity, I think, is, for us at least, one of the bigger ways to not be frustrated.
Yeah, I was just going to add into that as well. You know, just collaboration with other, well, I'm thinking in a provider sense, but, you know, with other clinics, just different resources, sharing resources, and, you know, just starting small and knowing, like Ed said, you know, one little bit at a time. Yeah.
I love the work that Jennifer's doing, and as she's talking about the work she's doing in the homes, I'm starting to think about, well, what does that mean to get into the homes to prevent falls? You know, who could do that? Who all could do that? Who would be willing to do that? And so those are the sorts of things of these sorts of opportunities start to create those networks. You're going, huh, that's interesting. Can you teach me how to do that? So I think more of this sort of cup of coffee and a conversation is really, really important, I think. You know, so I'm grateful for what I've learned from my colleagues going, huh, I've got about a half a dozen things to go, well, this is interesting. I wonder what that means for us. How could we do that?
Yeah, Tom, thank you, Ed.
Yeah, Josh, just wanted to call everybody's attention. There is a comment Kelly posted in the chat just about an example of community partnering in Maine. So I know we're up against time here, but just wanted to direct everybody to that. So thanks, Josh.
Yep. Thanks, Tom. I appreciate it. Yeah, Kelly shared a great example there of how, you know, a community really collaborated, thought out of the box, the partner to come up and produce a solution. We are butting up against time, like Tom said. We have about 3 minutes left here. For our presenters, any key learnings or insight you'd like to share that you didn't have an opportunity to share very briefly here? Just again, wanted to give you that opportunity. I know some of you all had to rush through your presentations and you did a great job of staying on time. But again, just wanted to extend that opportunity before we conclude here.
Well, one of the e-learnings that, you know, I came across that was really important, it's also in the toolkit, is Smiles for Life, and they have videos and instructional videos on how to apply silverdiamine. So that was really helpful. And the Project Echo, I think too, going back to sort of people collaborating and learning from each other, also important.
Excellent. Thank you, Lynn. Okay, well, at that, we'll conclude our webinar here.